Pearson Rabbit's story begins with Dr. Stephanie Pearson, a passionate OB/GYN at the height of her career. But when a shoulder injury struck during a precipitous delivery, her dreams were shattered, leaving her unable to practice medicine. Determined to make a difference, Stephanie became an advocate for her peers, guiding them through the complex disability process. Alongside insurance expert Scott Ravitz, Stephanie founded Pearson Ravitz, a company determined to approach insurance differently. Together, they set their mission to educate and empower physicians to protect their most valuable asset, their income, and the most important people in their life, their family.
Today, Pearson Ravitz serves the medical community in all 50 states. At Pearson Ravitz, they understand the unique concerns of physicians. Physician-founded and physician-focused, Pearson Ravitz builds human connections before they create quotes. Life can change in an instant. It's hard to imagine that a sudden illness or injury could leave you and your family in a devastating financial situation. But with a little planning and guidance, you can prepare for every possibility. Visit PearsonRavitz.com today to schedule your consultation with the Pearson Ravitz advisor.
Finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Hello, everybody. Welcome back to another amazing episode of BS Free MD with your hosts, Tim and May Hindmarsh. And we actually are doing a full-on fun science, medical science episode today, believe it or not. We have
With hopefully helpful tips and tricks to get you through this season of not Christmas, of I don't know, Sneezemas.
Yeah, well, today we're going to talk to our friend Dr. Brad Block about some common ENT problems, myths, and misconceptions. And Brad Block is a renowned otolaryngologist based in Long Island, New York.
I think it's pronounced Long Island.
And he lives there with his wife and 3 young sons, and maybe we'll hear from them in the podcast. He's not only a partner at ENT and Allergy Associates, but also the brain behind actually a great podcast called The Physician's Guide to Doctoring. And his journey in medicine began at SUNY Buffalo, where he graduated with research honors, followed by an ENT residency at Georgetown. And when he's not in clinic, he enjoys surfing, skiing, smoking meat, exercising, and quoting 80s movies. It sounds like your brother from another mother,
That
Tim.
is 100%
His
correct.
approach to medicine focuses on building rapport, trust, and efficient patient communication. We haven't spoken with him in a while. We're excited to see him again.
And like when I push that button, he magically appears.
Welcome to our show.
Well, thank you so much for having me. I've been really excited to do this.
I know. So, okay. Why don't you share for our audience? We know a little bit about your podcast, The Physician's Guide to Doctoring, but why don't you tell everybody a little bit about it? What inspired you to start that?
So it's when I started practicing, I realized that a lot of my partners were able to move through their office hours a lot more efficiently than me. So I didn't know why I was so slow. And I remember that was something that was in my training as well. My attendings were like, you really take a long time seeing patients. Why don't you? So well, how can I, aside from just interrupting them, what am I doing? How can I move through quickly? And so I looked into it, and there was this concept called social engineering, where you can engineer a social interaction. Now, this isn't a social interaction, but nonetheless, you should be able to apply the same principles. But a lot of that stuff was for dating or sales. And I think actually, if you look up social engineering now, it's more used to guess people's passwords. So different, that's different area. But so a lot of these people were professional coaches, or they'd written books on optimizing these different types of interactions, but it wasn't being applied to medicine. What I had learned was you got to make sure you're listening to your patient and listen. Unless you're not listening, you're not paying attention to their pain enough, just telling us all these more nebulous advice, but not how to engineer the interaction. like how to do it more methodically, so that not only do you get in and out of the room faster, but the patient has a better experience. And then the patient in the waiting room and the patient waiting at home to get an appointment, all of them end up having a better experience because you're able to manage the visit instead of reactively, but proactively. So that was the idea when it started. But you can't just call up strangers and be like, hey, I don't have a podcast yet, but can I interview you? So I just started interviewing people within my immediate circle, which, my brother, who has a PhD in health policy economics, and, my classmates from medical school who are now experts in whatever field they went into. So, I had these access to these experts, but it wasn't all about the doctor patient visit. It was just about anything that a doctor might have questions about. So my topics really kind of exploded into being, and the tagline is everything we should have been learning while we were memorizing Krebs cycle.
Right.
So it covers a lot of material. And now I've kind of pivoted. I stole a bit from Ted Lasso, and that's, trying to help physicians be the best versions of ourselves. So that's kind of what my podcast is now. And a lot of it still focuses on that doctor-patient interaction, but it covers the gamut of really anything that a physician might want to know. And I have an episode coming out soon, unclear when this is going to be published relative to when we're talking about it, but like on points and miles from your credit card. So that's not something we should be learning in medical school, but like, if you own your practice or have side gigs, and, that's something that physicians should know about. So, really I cover a lot of ground.
That's a cool episode. Me and my son will both listen because we're obsessed about trying to figure out the most points values per card used.
Well,
That's
yeah.
our side gig right there, figuring that
And
out.
then of course he doesn't have to pay any annual fees because
he's in
he
the
has a
military
discount. So then
So that's huge. It factors
Yeah.
in big time. But anyway,
Oh yeah.
I love it. I mean, it's true. When we started practicing medicine, and our patients make fun of that term because it is, you learn all this basic stuff and you learn the gist of your craft. But then you get into the real world and it's like, oh shit, I don't need all that stuff. I really need this, the meat of
Yeah.
what I'm seeing every day. And so that's
Yeah.
what's beautiful about your podcast is it's hopefully, for this fresh out of school or residency, but even for some of us who are like, yeah, I haven't kept up with whatever, this is really good info that I can use. So,
But
yeah, I'm
the thing
mid-career.
yeah.
So it's the podcast is for me. Like
Yeah.
I'm the avatar. I'm the audience.
Yeah.
So everyone that I have on the show, it's for questions that I have. So it definitely applies to people who are just
Yeah.
starting out, but still definitely applies mid-career too, because that's where I am.
Yeah,
love it.
it really is amazing because I'm work urgent care and it's super duper busy at my new job, and they want us to see 4 or 5 patients an hour. So how do you efficiently get through that and still practice good medicine and still be ethical and not just give everybody Zithromax, which would be really easy. You just have the prescriptions pre-written and throw them like darts. And the thing I found, and I just sort of intuitively figured this out, is I have a fairly broad base of interest just in life in general. So there's usually some fact I know about a little bit about most things. So, the lady that comes in because her cat scratched her and gave her a skin tear because she's 95 years old and has a cat shirt on. I'm like, I just started talking about how we had to give our cat away when we moved. And instantly she's like, literally within 2 minutes, she was, are you taking regular patients? Because the doctor-patient relationship is 100% based on trust. If they don't trust you, you could be the smartest person in the entire world, and there's no therapeutic ability, relationship there at all. And so I just started doing that. Like, and I ride Harleys, and that one, guys wear a Harley shirt. But like all of a sudden, I am the authority on everything medical because I'm cool. I ride a bike, and it really is a fascinating thing. It hit me, this instant trust thing, because I used to wear a lanyard with Iron Maiden logo on it. And so it was like a social experiment.
And I'd be like, you're wearing that to work?
The people that didn't get it didn't care because they didn't get it and they didn't know what it was. The people that got it were like, this is, it was like this instant trust. So I've just kind of used that because it just moves the visit along so quickly. When people, their guard is down, now they trust you. It's like, okay, now we can get on to business. And it allows you to practice better medicine and not just necessarily give them what they thought they were coming to get, which is, what we're going to get into, now, cold and flu season, chronic, chronic sinusitis, all of these different things. Please explain
Well,
to us what a sinus infection is.
So I just
no.
want to actually mention you had said, getting patients to find some common ground to relate to. That came out in an interview I did with Nick Boothman, who wrote the book How to Make People Like You in 90 Seconds or Less. And so that's a big part of what he talks about is finding some common ground, some common interest. Because the minute you do that, like they come into your office, they're uncomfortable, they're sick, their dander is up, their threshold for learning new things, taking in new ideas is low. But the minute you can disarm them with some common ground or making them laugh, something like that, then their ability to take in new ideas, trust this new person, maybe change their mind about something, like they came in for a Z-Pack that you're throwing at people like darts, like, maybe now they'll be like, oh, this guy that likes Iron Maiden like I do, maybe he's right. Maybe I shouldn't be coming in 2 days after the onset of symptoms for antibiotics each time I have a stuffy nose.
Yeah.
Well,
Well,
exactly.
so actually, Tim threw out the big, threw you the nugget. But before we get to that one, maybe this is too broad of a question, but I want to know first what, like, I know what we see frequently as family practice, urgent care docs is the ENT stuff, the common things. But what's the most frequent cases that you get referred to, would you say, from our clinic that just come in all the
From
time?
folks like
Yeah.
us to
Well,
is a
Just
surgeon.
that's just like over
well,
and
so
over and over.
there's I'm a general otolaryngologist
Right.
I'm not at a tertiary care center, right? Like one of the university
Right.
centers. So
Right.
they're seeing different stuff than what
Yes.
we're seeing.
No.
We're seeing a lot of earwax.
Wow.
A lot of earwax.
Wow.
Lots of earwax.
So people
Yes, I remove a lot of earwax
self-refer to you for earwax.
for earwax. Yeah.
Wow.
But you have
Yeah.
a microscope to do
Really?
it like
I have
properly.
a lot of instruments. I have
A lot of
and
MAs removing earwax.
no. We do it ourselves. Yeah. So a lot of tools, a lot of experience, and a microscope, and yeah, that's
Okay.
it makes it. But sometimes, I've got someone will come in, it'll take like 30 seconds to take out, and I've got someone else who come in, like I might be sweating over it for 20 minutes. Like it's sometimes really hard. It's not always super straightforward. So yes, earwax is definitely the most common. So yes, 4 years of undergrad, 4 years of medical school, and 5 years of surgical training to be removing earwax many times a day. Yep. That's my life.
I'm sorry. Is all I can
No,
say.
that's wild though. But I mean, but the thing is, like, it's so unbelievably disabling when you're completely like when we lavage these people, and it's just like, I mean, it's like you've unstopped their ears, and it's kind of like leave the crutches and the donations at the front of the church. Like they really miraculously feel.
Oh yeah, they're super grateful. With COVID, we had to shut down. We were only taking emergency visits, and you needed to. This was like April of 2020, so like the height of COVID in New York, right? So New York was hit super hard. Our numbers were super high, and so we were seeing. But if you were seen over telemedicine, then you could see a doctor in person. You to basically demonstrate that it was really an emergency. One of the reasons we had to open back up was all these patients were like, I can't hear. And we're like, there's a respiratory virus that's killing people. And they're like, but you don't understand. I can't hear because of my earwax. We're like, that's not an emergency. Like, yeah. And so we had like once we opened back up, it was like a flood of patients that were all just like debilitated by the fact that they couldn't hear. Yeah.
Well, and you got the mask over their mouths, and so you can't lip read, and that's a big deal for people. It's a total change. I mean, I get that. I didn't realize how much I lip read because I have terrible hearing, and then on come the mask.
No,
I'm like, oh.
it's just the exact frequency of my voice with what you have.
So earwax, and then what else? When since people are self triaging to you, what would be the next big thing you deal with all the time?
Yeah, a lot of like throat mucus, post-nasal drip. Like I know we're going to be getting into that later, but people are like
really
debilitated by this mucus in their throat. I mean, it's all kind of this continuum of throat mucus, post-nasal drip, throat clearing, like just generalized posterior pharyngeal, nasopharyngeal throat complaints. Yeah.
Interesting. That
Huh.
really, because that's a whole gamut of what we've done in primary care, which is chronic cough. What causes chronic cough? Well, like
Yeah.
everything, right? I mean, there's a million different things. Well, but commonly it's from people's nose. It's worse when I lay down. It's worse first thing in the morning. I cough up ungodly. And by the way, it's green now,
Yeah,
and
that
green
one.
means go for Augmentin. That's what that
Yep.
means.
What about kids? What do you do a lot of pediatrics in your practice too?
So I see a ton of kids. Most of my surgeries are kids. Like I do operate on adults, like, septums and sinus problems and some sleep apnea, but some voice problems. But the bulk of my surgeries are tubes, tonsils, and adenoids. I do just endless amounts of tubes, tonsils, and adenoids. Yeah.
All right. Okay. So let's see. What I know I was going to
Are
ask
we?
you,
Is this like a quiz show? You're going to ask me questions?
not you. I was going to ask him, what are the common misconceptions and things? And I know you want to talk about mucus and postnasal drainage because I think I agree with you. We see all these people and you try to explain about nasal, postnasal drip and all this. And who was it? One ENT we met told us how many gallons of mucus the nose produces. It was like a couple of gallons. Is
No,
that right?
liters. It's a couple of
It's
liters.
the nose and the mouth produce like a liter and a half to a liter and a half
Okay.
of mucus a
Sorry.
day.
That's still
Yeah.
a liter.
It's a
I thought
ton.
That's
It's a lot of
yeah.
mucus.
It's
Yeah.
it's a lot. Yeah. You
that
People
is.
are very snotty. It's
Yeah.
So,
And that's without having a cold or allergies or whatever. Yeah.
so what's a big problems that people come in with it? Just like they don't like how much their nose is dripping and running, or what are the presenting problems with that?
Well, I think we should get into that misconception issue, and it's a common misconception among physicians as well. That whole postnasal drip is the most common cause of cough, and I know it's on like exams, but it's just wrong. It's just completely wrong. Postnasal drip, first of all, not a thing, not a diagnosis, not a. It's a symptom, right? And sometimes you can see that mucopurulent exudate dripping down the posterior pharyngeal wall, but it doesn't make you cough unless you are neurologically not intact, because you should be able to swallow that mucus, not aspirate it. You shouldn't be drowning in your own mucus. So if you're not drowning in your own mucus, why would you be coughing it back up? It just doesn't make sense. It doesn't make physiologic sense. That's the function of the larynx, is to keep stuff out of the lungs so that it gets swallowed. So if you have a competent larynx, you should be able to just swallow your mucus. If you can swallow your coffee and your milk and your soda, you should be able to swallow your mucus. It's not postnasal drip. What it is colds can make you cough. And so if you have cough, it starts with nasopharyngitis. That's why we were swabbing everyone's nasopharynx at the beginning of COVID, like so we could get the most accurate, because that's where it starts. You get a cold, it starts off in the nasopharynx. That's where you get the sensation in the way back of your nose, that like, right? And you might see it dripping down the back of their throat. But ultimately, that's a viral upper respiratory tract infection that might affect the lower respiratory tract too and make you cough. And what I see probably most often, particularly in kids, is when kids have a cold and one of the predominant features is cough, and it's worse at night. It's worse when they lie down. They cough in their sleep. Everyone's like, oh, it's because of their postnasal drip. No, those kids probably have asthma. And it flies under the radar so often, or it gets diagnosed, but nobody notices the pattern. So it's like, yeah, they were on an albuterol nebulizer and they did great. It's like, okay, well, now that the cough's back again, did we use the nebulizer? No, because nobody told us to. Like they told us to do it that one time and we did it and he did great, but I thought this was like a different problem. And so I see asthma, like it's not really in my specialty, but like who has asthma? Like the kids that have middle ear infections, the kid have huge adenoids, the adults with chronic sinus infections, the adults with nasal polyps. Like the Venn diagram of ear, nose, and throat problems and asthma has a huge overlap. So I end up seeing those people when they're having asthma exacerbations because they're having some ear, nose, or throat problem. And so I end up I don't manage their asthma, but I'll like help them with it a little bit and then send them back to their pulmonologist or their allergist, their primary, whoever's managing their asthma, because a lot of times they don't even know that's what it is. So I'll end up making the diagnosis because, they're coming to me because they think it's postnasal drip, but no, postnasal drip, not a thing. And ultimately, much more complicated. Post-nasal drip is much more complicated than one would think it is. Like the thought process is often like, oh, I'm the patient. Doctor, I have post-nasal drip. Okay, here's Flonase. Okay, that's it. But ultimately, like it could be the asthma that's making them cough. And then therefore they're calling it post-nasal drip because they think it's post-nasal drip. Or they throat clear a lot. Well, if they throat clear a lot, what could it be? I mean, God forbid it's laryngeal cancer or something like that. But more often it's either habitual throat clearing, extra esophageal reflux, maybe something that I see a ton of, anxiety. So the anxiety doesn't make you actually throat clear, but what happens is that extra sympathetic tone causes their mucus to be more viscous because they're in fight or flight. So they're making less saliva. They're making like less of the watery component of their mucus, so it gets more viscous. So now they're feeling all this goopy mucus in their throat. Why? Because they're just in fight or flight all the time because of their anxiety. So the anxiety could be causing postnasal drip. It's not making them think they have postnasal drip. It's causing these like real physiologic changes. So like there's so much that goes into the upper airway physiology that when someone goes, oh yeah, it's just my postnasal drip, it's like, well, that could be, or it could be a sinus infection. It could be. That does happen. It could be a cold. It could be allergic rhinitis. But typically, most of those are also going to cause prenasal drip, or what most people would call a runny nose. So there's going to be other signs. But when it's just postnasal drip, it can be really complicated to unravel and to get them to elaborate on it and not just kind of hang on to that as their diagnosis can be a challenge too.
So, what you say about the post-nasal drip, I think, at least in my experience, is that people that say that are usually referring to allergic rhinitis. But the sensation is, they don't really pay attention to it running forward as much as running backwards, if that even makes sense. But what about, I'm thinking of patients that come in where it's worse at night when they lay down and they're like, as soon as I lay down, I can feel this mucus in the back of my throat. Is that a sympathetic thing, do you think? Or could it be the asthma because that can be worse at night? Any thoughts on that?
GERD.
Or GERD? No, but not what's when they first lay down. Yeah.
Yeah, I mean it's hard to know what that
Okay.
singular component is because the asthma would be cough. If they're coughing, and it doesn't mean that it is asthma. It could be reflux, right? But very commonly it is, and I've found that wheezing is not a reliable determinant of whether or not it's asthma. I'll often give them albuterol, and I'll openly admit I overcall it. So I probably try albuterol on more people than would benefit from it. But again, it's a trial, and if they respond, then great. There's your answer. And I often, you'll determine it from a pattern, like it's viral induced. So it's like every time they get a cold, like, oh yeah, no, I don't have asthma, but I've had bronchitis. Yeah, I seem to get bronchitis every winter. Like who gets bronchitis every winter, right? Like every cold goes to their chest.
My girlfriend.
No, I
She
tell people the secret. I said bronchitis is just a secret code word we use so we don't feel guilty when we give you the Zithromax. Yeah, you just have a cough and a cold. And and that's the thing. Like I've told lots of pediatric, families, I was like, not all asthma wheezes, but all asthma coughs. So it's the first thing you should think of in a kid with a chronic cough.
Yeah.
But this post-viral cough syndrome is a real thing too. People will cough for weeks and weeks and weeks, and then like
Yeah.
I've never had a cough like this after a cold. And I said, well, then you're lucky.
Yeah.
Because you can cough for 3 weeks.
And that's the thing. It's the pattern that tells you more than anything. Like one singular event, yeah, you're not gonna be able to tell. Does this kid have RSV or parainfluenza or coronavirus, right? So some lower respiratory tract infection that would make anyone cough. No, but if it's a recurring event, that's how you end up with going down that path. But yeah, but the mucus that goes down the back of your throat when you lie down, like that's the thing is like all mucus goes down the back of your throat. That 1.5 liters of mucus has to go somewhere, and it's hopefully not getting aspirated, so it's going to get swallowed.
So let's go down the path of the sinusitis and sinus headaches, because that's a a big can of worms, and I don't know, we preach it till the cows come home, but maybe we have missed something. When patients come in, there's do all the educating about what sinusitis means, because like, oh, I have sinusitis, I need an antibiotic. Well, so when we tell them it's just inflammation of the sinuses, most common causes, usually viral, etc. But then there's some people, it's like, I always get a bacterial sinus infection. It's never viral. So
And it's always Thanksgiving week.
so is there
No, that
there
happens. We have
are
a
a
lot of
few.
people, they get sick the same time of year. So they're like, it must be allergies because it happens the same time of year. And you're like, no, it's just a lot of people get together the same time of year and get each other sick. And they're like,
Right.
no, I was told it's allergies and therefore it's allergies. And, a big challenge of my job, and I'm sure yours as well, is just like untangling this knot of, this is what I know to be true. And then you've got to kind of peel away those layers to convince them, which is going to be much easier if they're an Iron Maiden fan, certainly.
Correct.
Yeah.
So tell our listeners then, when people get a sinus pressure, congestion in their face, their cheek, their forehead,
Yeah.
um, from fluid that's there, are those usually all, what's the percentage of time that those are all just viral or from allergies versus bacterial?
So I'm going to blow your mind right now, because the way that it should be thought of is there's the sinus infections are secondary infections.
Right.
So you're never going to get a sinus infection de novo. And I shouldn't say never, because there's never, but like the overwhelming majority of the time, sinus infections are secondary infections because you have bacteria in your sinuses constantly. It's just always there. But because you have mucociliary flow, the mucus is just moving that mucus. So it's like a river, like it just doesn't have an opportunity to dig in. But when you get a cold, now the mucus gets more viscous, the mucosa gets swollen and it can't move the mucus quite as well. And now the bacteria has an opportunity to multiply. And per Medicare, and I'm not sure if this stuff applies to you guys as well, we shouldn't be applying antibiotics until they've had at least 10 days, or it might even be more than 10 days of symptoms, because then you get dinged from MIPS, right? It determines your reimbursement. So this is one of those quality metrics. So unless there's some extenuating circumstance, right? I've had patients that get orbital cellulitis from sinusitis they'd started out in a cold, but they've only had symptoms for 2 days. And now suddenly one of their eyes just swells up and they risk losing their vision. So, right, it doesn't follow this rule where it has to be 10 days, but they have those because sinus infections, bacterial sinus infections, do also resolve spontaneously. So, the recommendations from Medicare is you need to have these cold symptoms for at least 10 days before you take antibiotics, because of this, because it starts off as a virus. And either you start getting better because the virus is going away, and then you get these bump in symptoms. So now suddenly you're worse because the bacteria have dug in and multiplied and given you this bacterial sinus infection. Or that bump is not really noticeable. You just plateau. You just like, I'm just not getting better and it's been too long. So ultimately it's going to start off as a virus and then turn into, so it's going to be a secondary infection.
Yeah. And that's what I've told patients. I'm like, sinusitis is a secondary infection. Actually, otitis media. I mean, you plug up your station tube, you can't drain. Boom, there's bacteria in your
exactly.
ear.
And most of those also go away without antibiotics. So the antibiotics don't help for otitis media. The antibiotics don't help clear the fluid. Nothing helps clear the fluid. Some ENTs will prescribe steroids. I don't. The literature on there, it seems a little like wishy-washy, at least for systemic steroids. But for everything else, the literature is pretty definitive that like nothing's going to dry up that fluid. You just have to wait. And especially in like barotrauma where they fly and then they have a lot of pain on the way down on descent, and then they can't hear because they've still got fluid in their middle ear. Their drum is going to be erythematous from vasodilation from that stretch on the drum that caused that fluid to happen. But it's not otitis. I mean, it's serous media. It's not bacterial. It's not. So nothing, you just nothing. There's nothing. You just got to wait, and it's going to get better, which is actually interesting about the whole flight thing. Cause people come in all the time cause they're like, can you take out this earwax before I fly? Cause I'm afraid I'm going to have an ear problem. Never do I get someone who's like, I've got a stuffy nose today and I'm going to fly. Am I going to have ear problems? But those are the people that should be coming in. if you have a stuffy nose and you fly, you should be taking Afrin and maybe Sudafed and maybe using like these special earplugs, because that's when you're at risk for having ear problems.
Yeah, we would see people like that occasionally. They'll come in with the cold, and it's like, I'm freaked out because, I'm going to fly, and what's going to happen?
Well, the real freak out is the 3-year-old.
Yes.
The inconsolable 3-year-old that's,
Just give me
losing
the
their...
antibiotics, doctor, because my kid's crying all night long, and I want to go to sleep, and their ears red. You look at it, and how do you convince parents not to give antibiotics for an ear infection? That's a viral ear infection. When, at least from our men, that's the hardest thing. I mean, people, you can usually talk off the ledge about the sinusitis. It's like, yeah, it's a cold. It's got to run its course. These are the typical symptoms that we're going to look for. But unless you're seeing a kid in the office, and I know some pediatricians are good about seeing them every day to just keep a close eye on them to see if things change. How do you sort of convince parents about kids' ears to sort of watch and wait versus antibiotics?
Well, I definitely want to get back to sinuses because we haven't talked about sinus pressure yet
Okay.
and congestion, because that's a whole thing that I definitely want to cover.
Okay.
But for otitis media, it really depends if they're less than 2 or older than 2. So the recommendation is if they have an ear infection and they're less than 2, you should be giving antibiotics. But if they're greater than 2, then the recommendation is give at least 24 hours of NSAIDs before you give an antibiotic. And what I wouldn't bring them back serially to check on it, because if the kid's having persistent pain and fever, then you might want to give the antibiotic. But if they're not having pain and fever, then it can be really hard to tell like white mucus from pus behind an eardrum in a moving, screaming child. Yeah. And so like if the kid's comfortable, then what is the antibiotic going to do for them once they're over 2? By the way, we didn't say this at the beginning of the episode, but like for the listeners, I'm not your doctor. This is not medical advice. The disclaimer.
Exactly.
This is
even though you can hear me.
Yes. Even though you can hear me in your ears, like I'm not talking to you.
Right. This is general information.
Yes. So
this is Google Docs. No.
Oh, exactly. No, it's not.
I'm kidding.
So it can be hard to make that diagnosis, but if you have a snotty kid who's totally comfortable, then what are the antibiotics doing for them anyway? Because it's not clearing the fluid. All it's doing is taking away the pain and fever. So and decreasing the likelihood of complication, like meningitis or some like terrible complication of otitis media that like is extraordinarily rare. It is extraordinarily rare. So the risk of C. diff might even be higher than the risk of a complication from otitis media. So you gotta pick your poison in that situation.
Are you looking for alternative investments and tangible assets that help you build and protect your wealth while empowering your financial future? Look no further than Eckhart Enterprises. With over 37 years of experience in the industry, Eckhart Enterprises is your trusted partner in the world of alternative investments and asset management. They have a track record of success with more than 1,300 investors on board and over $700 million in capital invested in tangible assets.
Their specialty lies in offering immediate cash flow opportunities through mineral rights investments so that you don't have to wait decades to see your investments pay off. Their unique AML approach, born from decades of experience, focuses on aggregating, maturing, and liquidating assets strategically to maximize returns. Join Eckhart Enterprises. Visit EckhartEnterprises.com, spelled ECKARD enterprises.com today to begin your journey toward building and protecting your financial future.
For more information about alternative investments and asset management, visit EckhartEnterprises.com. And remember, Eckhart Enterprises is your gateway to tangible assets and lasting financial success. Contact Eckhart today.
For more information about alternative investments and asset management, visit EckhartEnterprises.com, spelled ECKARDENTERPRISES.com. And remember, Eckhart Enterprises is your gateway to tangible assets and lasting financial success. Contact Eckhart today. giving kids antibiotics continuously when they're young, I mean, it's going to just start to destroy their gut microbiome. And then there's all these, we know the ramifications of now kids are getting higher rates of all kinds of autoimmune diseases that can be linked to bad gut microbiome stuff. And so you start to think, how many times you just throw some antibiotics at a kid who has a viral otitis and you're harming them by just putting them on this, causing antibiotic resistance, as well as jacking up their own gut microbiome and making them resistant. I mean, it's a lot more.
Well, yeah. I mean,
And you just throw tubes in them.
Yeah.
You're
exactly.
done. Yeah, tubes, no problem.
Yeah, exactly. No, but it is. I mean, it is fascinating because, my father graduated in 1958, so he practiced medicine at essentially the dawn of antibiotics. I mean, there's, people don't really realize how new they actually are.
Oh yeah,
because we take it for granted. So, and I've said this, I don't know how many times, but we don't really know in totality whether antibiotics will actually be a net good or a net bad for humanity. We don't know. It might take 200 or 300 years to know that. Right now, antibiotics are clearly a net good for us alive. Pneumonias used to kill everybody at the turn of the last century. Old man's friend. What did William Moser call it? The king of the man of death, the captain of the man of death was pneumonia. Now, often it's an outpatient nuisance. You treat it as an outpatient. But you think, what happens after we do antibiotics for 200 years or 250 years? Will we have wiped out enough good bacteria that actually it will be a net negative? Who knows, right? I mean, it's the nature of science. You don't know.
So for whatever reason, the wild type, not resistant stuff, tends to just outperform the resistant stuff. Thankfully, we're in this situation where by the grace of God, the wild type does tend to outperform it. So as long as you're, being judicious with the antibiotics, there really shouldn't be these long-term detrimental effects. But to your point, who knows? Who knows what's going to happen if we're still around to see it?
Yeah, well, we won't be.
No.
And we won't die of pneumonia. So that's good. But, our great-great-great-grandchildren, who knows? They may, they'll be like, thanks, Dad. Thanks, Granddad, for all.
Well, they wouldn't be here if it weren't for antibiotics, because I would have died from some toe infection.
There you go.
There's that.
Welcome.
It's like, well, it's like the Oregon Trail, right? Like you think about those people, and it's like, they're getting cut and they're getting, all nasty stuff, like Clostridiums everywhere because their horses are crapping everywhere and all this kind of, and it's just like, how did anybody survive?
They had a lot more kids and they just expected a bunch of them to die.
Yeah,
I mean,
it's 100% correct.
It is just, we thankfully don't live in that reality.
Yeah, no, it really is something. All right, let's do the sinus thing because
So you may use this term congestion, which is triggering for me. I have to say, congestion is triggering. And the reason is because what I've found is when people use the word congestion, they use it to mean lots of different stuff. So what it technically means is filled with fluid. And when they're pointing to their sinuses and they're saying their sinuses are congested, they mean they're filled with fluid. But they don't mean they're filled with fluid. They mean it feels like they're filled with fluid, or there feels like they're filled with pressure. So what we find is 9 times out of 10, when someone goes to an ENT or their primary care physician and their chief complaint is sinus pain or pressure. But I would expand that to mean sinus congestion as well. So don't confuse nasal congestion with sinus congestion, because nasal obstruction is one symptom. Sinus congestion is a different one, because they'll point to their sinus and be like, they're congested. So 9 times out of 10, those patients have a sinus headache and not a sinus infection. And sinus headaches are almost always migraines. And so those patients don't even have sinus problems. And I'm going to go conspiracy theory here, because the pharmaceutical companies have access to the same data that we do. And they know 9 times out of 10, when someone has sinus pressure, they're having a headache. And so what is Advil cold and sinus? What is Tylenol cold and sinus? But upcharged Tylenol and upcharged Advil, because you can get the whole box of Costco-sized Tylenol for $20, but when you take those little peel packs of the Advil cold and sinus that have all the different components in them, right? Ultimately, it's just the Advil that's making your headache go away, that's making your sinus pressure go away, but they're making a lot more money because they've got the box with the arrows pointing to the sinuses, and that's how you're feeling. So those are migraines almost all of the time. And so those patients that come in and they don't have some prodromal cold and they just have this sinus pain and pressure, they're not just getting some de novo sinus infection. They probably have migraines. And there are some ENTs out there who will do this procedure called balloon sinuplasty, where you put a little wire into the sinus, you dilate the balloon, and you open up the sinus. And they're like, it'll help your sinus headaches. But those are often migraines. And so it's pretty controversial in my field because you have some people who run these kind of balloon mills where they'll advertise to get more of those patients because it happens to reimburse really well. So they'll advertise and they'll be like, come, well, do you notice that when the weather changes, you get pressure in your sinuses? If we open up those narrow openings, you won't get that pressure anymore. Yeah. Who notices when the weather's changing? Patients with arthritis and patients with migraines.
Migraine. And that would, I'm one of them. So I totally relate.
Well, you have both. So good for you.
I do. But the pain in my knee is really in my knee, not in my sinus.
No, it really, that's really amazing.
There you go.
So, okay, 10 days for treatment. That's kind of what I've been telling people. That one all makes sense. I like doing discriminators of, does it go into your teeth? Like if it's your maxillary sinuses, a lot of people come in with this dental pain that might actually be their sinus. And so, that one, I also I will treat people earlier if they've had a bunch of problems, especially if they've seen an ENT and have ever been talked about getting a procedure, like a window or whatever. And then I'm like, okay, this is a real thing. The problem is it's hard to differentiate.
Unless that ENT talked to them about the balloon.
Yeah.
It might be a real thing because there's real, there people, I use the balloon in the operating room, get into the frontal sinus. Like it's a real procedure, but a lot of times it's being used otherwise. So, but yeah, like a lot of the patients that have chronic sinusitis, it's different because their mucosa just sucks. It just sucks. And so, imagine healthy mucosa is just constantly creating and moving mucus, but theirs just doesn't. So the minute they get a cold, some of them, like 100% of the time, turn from cold to sinus infection. It's just a soupy mess in their sinuses, like immediately. So if they've got chronic, then it would be an acute exacerbation of chronic sinusitis. That's a different situation. Yeah.
So do they get better if you open them up? Like if you put a sinus window in there or use the balloon or whatever it is, does that help? Like, does it drain better, or is it just that their mucus or their mucosa is so terrible that there's not much you can do?
Well, so opening up certainly helps for a couple of reasons. One is, it allows them to drain better by gravity, although the maxillary sinuses actually drain at the top. So the mucosa pushes mucus up. And the way that I, envision it is like, was it Sisyphus who's pushing like the boulder up the hill, right? So all you're doing is you're kind of lowering the hill for Sisyphus. You still got to push the boulder up a hill, but it's a lower hill. So it's going to help. Also, by opening up the sinuses, you allow topical medications to get in there because it's not just a infectious problem, it's an inflammatory problem. So now they're able to wash their sinuses with budesonide. And so now you're getting steroids into the sinuses directly rather than having to put them on systemic steroids. You can actually wash them out. They can wash themselves out with antibiotics. So you do like culture directed antibiotics. So it's not just you'll open up their sinuses and they're cured. Like they still have this crappy mucosa that you have to help them manage.
No, that is super helpful. Actually, we should get CME for this, honestly.
Yeah, I feel like I am getting CME.
Well, yeah, just, but because it really that's actually a really good point because there's lots in medicine that's that way. I mean, we've really gone down this whole down tons of rabbit holes with the podcast, but this idea that you're your best doctor. We give you advice, you have to implement that advice. And it drives me crazy in the whole diabetic world because it's like, there's a pill and an injection and all this, and they advertise it, and these people are still morbidly obese. So it's like, it's okay to be morbidly obese if you take the medicine. Well, what if we worked on the root cause? So it's the same thing. Like people have crappy mucosa, you go in there, you do a surgery, but the surgery is only part of the solution. It's not the solution.
Yeah. Yeah. Yeah, exactly. Exactly. Well, the whole obesity thing, like that's a whole can of worms. We could have a whole nother discussion. I'm sure you guys have had tons of those episodes because there's like all these social determinants of health. There's things that you can control. There's things you can't. There's things that make it more likely. Because like if you've got someone who's from like a super skinny athletic family, and you've got someone who's from a sedentary family, like just they're not starting on third base, so they're starting on
Right.
different bases. So you're like, how do
Right.
we
100%.
how do we help those people help themselves, right? We can't put the onus completely on them, but at the same time, there is some, they're the ones living with the consequences. Sorry, that's like a whole. This is stuff that we talk about on the show as well, on my show as well. Is like, how do we best help people in those situations?
No, but that's exactly
Right.
it. I mean,
Right.
I think you nailed it though. It's how do you best help people to help themselves? And that's
Yeah.
different help for every single patient. But
Yes.
but that's the real practice of medicine is, how can I help you be your own best doctor, so to speak?
Yeah.
And sometimes it's you have some really unhelpful beliefs that we need to challenge. Sometimes it's like you have a piece of your femur sticking out of your quad. We probably need to take that to the OR. But they still have to do rehab after. I mean, you can do the best
Yeah.
I mean, I talked to this one real crusty total joint guy, and he said that in training, this one surgeon said, "Don't do good surgery on bad patients." And he was just like, be really careful on who. Really, what he's saying is, be really careful on who you pick to do
You
surgery
got
on
to pick your
because
patients. That's one of the. I mean, technically, doing surgery can sometimes be technically challenging, right? But sometimes just patient selection and making sure they're understanding, and you got to make sure that they know not only what they're getting themselves into, but you can't set their expectations inappropriately. You got to sometimes bring their expectations back. Like, yeah, I'm going to take out your tonsils and I'm never going to get a sore throat again because my friend who had their tonsils out, they never get sore throats. It's
Right.
like,
Mhm.
whoa, 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 whoa. Or like fixing their deviated septum is going to help their postnasal drip. I hope all the listeners know after this episode that postnasal drip has nothing to do with the deviated nasal septum, but like that's still going to be, you got to make sure that that's not their expectation. And there might be some element of mind reading that needs to happen to know that that might be their expectation because they might not bring it up. And then afterwards, they're like, well, how come it didn't fix my postnasal drip? And you're looking back at your notes and you're like, you didn't mention anything about postnasal drip. So, yeah. So picking your patients
exactly.
and managing their expectations is a big part of it.
If you fix my boxer's fracture, will I be able to play piano? Well, I didn't know how to
Sure.
play piano
Sure you
before I had the fracture. It's that whole thing. So
So I want to know since you see so much earwax, what your favorite advice to patients is on how to deal with that, what to do about it, if anything. Because I know what I've told patients, but what do you usually tell them?
I think you two might appreciate this. I tell people to clean their ears like they clean their bottom. Wipe the outside, but don't stick anything on the inside.
that's really good
Yes,
advice.
yes, I've heard that before. I
Oh
love
yeah,
it.
you've heard that? I thought I made it up. All right.
That's a proctolaryngologist.
There
That's
you
Yeah,
go.
I like
There you
that.
go.
exactly.
So
Exactly.
do you
But
tell
I've
them
got
to
a whole
put
spiel. I've got a whole like thing,
does
that we all
does
say to
Like
people
so,
over and over.
sticking toothpicks and pen lids and
oh
things like
the
that in there.
big pen the big pen lid like
That would
Oh
be my
yeah,
literally.
that's a
father with
common
a
one.
toothpick.
Hairpins,
My dad would
hairpins.
do
Yeah.
that with a toothpick at the table. Like I'm rattling
Oh,
out my dad, but literally. Oh
at the
yeah.
dinner table. Oh
Oh
my,
yes. After he's done with the
picking
like
his teeth, he picks his
teeth
ears.
right to the
Okay.
ears. But what I've told patients before that suffer with really bad debilitating impacted earwax to even do things like putting a couple drops of oil, like olive oil in there or a baby oil,
Does that
just
help?
to drip it in.
Colace.
Yes, well, we use that in the
Yeah.
office.
Let's,
I've told
let's
patients
use
for bad
Colace.
ones
Yeah.
too. Yeah. Um, we
I
try
didn't.
not
I
to give
didn't.
that one away because then they can come in and we can use it. But
That's right. It's like the Colonel's 11 herbs and spices. Ours is
or
Colace.
peroxide works well too. But you got to be careful that if you have a perforation, you don't want to be dumping peroxide in your
Oh yes. No,
ear.
definitely not. That's going to cause. And then actually, because peroxide has an exothermic reaction, you can also give them a caloric and give them vertigo because it starts warming up their ear. So that's always fun.
Oh,
Um,
we have a story about that. We had the urgent care we worked at. We had this mill of medical assistants that would kind of come in there and go like continuously of turnover of staff. But when we had all these people come in all the time with impacted ears with all this cerumen, the job of the MAs was to, the docs would just go, oh yeah, they need their ear lavage because they can't see anything. Well, the training, let's say, was lacking. And so we had this one MA who I think thought she knew how to clean out an ear, but did not. And so
I think I
she's
know
like,
where this
yeah,
is going.
yeah. So she just filled up the little syringe with water, ice cold water,
Ooh.
and started, pumping and squirting away. And the next thing you know, this guy's passing out. She's yelling, help, he's sick, he's throwing up, he's dizzy. What did I do wrong?
Gave him a
Everything.
caloric. Well,
It,
his inner ear works clearly
yes,
because
it was a
that's what we
it's
do.
a teaching moment, right?
Yeah.
But yes, so
No, I've got cold water calorics from getting water in one ear water skiing, and it
yes.
is,
Oh,
in 40-degree water because I was an
Oh, you
idiot.
thought I was going to say at the time we went barefoot water
Oh,
skiing. That
that
happened to
yeah.
me.
Took
And
me barefooting in the morning, and she got a blast of 55-degree water in one ear and would puke down the
I
side of the
threw up
car.
out the truck window all the way down the side of his boat on the way home. So it's
that
a
sounds
real
awful.
thing. Yeah. Any more tips, tricks, or thoughts on ENT situations that you see that come to
And stuff
mind?
that we get wrong. Like, I'd love
Yeah.
to know what we,
Well, the
when we
migraine,
when you
the
sent,
migraine.
the sinus balloon thing, that was good.
Yeah, the post-nasal drip, the migraine, those are really the two big ones. The earwax. I mean, just
Right.
more for the listeners than for you guys. Just what I tell people is the ears have a system for. Oh nope, actually, now I just thought of it, but I'll finish my thought. The ears have a system for making wax and pushing it out, and the less you interfere with it, the better it works. The only people that I've found that can do something proactively, if you've got like dry skin, itchy, dry skin in your ears, that skin mixes with the wax and can form a hard plug. So if you treat the dry skin,
Mm-hmm.
it mixes less with the wax and becomes less of a problem. So you treat your itchy ear with like a steroid cream or moisturizer or whatever, then you're less likely by treating the skin condition to have a wax condition. But otherwise, just let the ears do their thing, because it's actually the chewing motion that the TMJ wiggles the canal skin that causes the wax to kind of rifle its way out of or march its way out of the canal. And because the TMJ borders or shares a common wall with the ear canal, this is the segue to the next comment. There's the next pearl, which is one of the most common causes of ear pain is TMJ.
Yes.
So if you've got someone with ear pain and you look in the ear and it looks totally fine, push on their TMJ. Like even stick your finger in their ear canal, have them open and close a couple of times, and gloved finger clearly.
Yes.
And if they're like, ooh, ah, ooh, that's the spot, it's very likely TMJ. And then you can just give them, Motrin, mushy foods, have them follow up with their dentist.
Get the night guard going.
So is there
that kind of
anything,
thing. Yeah.
I guess we're getting close on time. This is probably but this is another thing that drives me crazy. Like whether you call it barotitis or these people that have these continuously plugged ears because their eustachian tube is crap.
Yeah.
Is the only thing you can really do is put a tube in them, like an actual because like none
So
of
there's
this
a newer
stretching out
procedure. There's a newer procedure called it's also a balloon, where you can actually balloon open the eustachian tube to help the eustachian tube work better. One of the drawbacks of that is you can get a patchless eustachian tube. So now it doesn't close, and then you're hearing your voice through your ear instead of out of your mouth and back into your ear. So it's called autophony, and I'm probably not pronouncing that correct. Autophony. But that's another thing that you can do. But a lot of people that have ear fullness, if the eustachian tube's moving normal, I mean, not the eustachian tube, the eardrum is moving normally, the ear fullness can be sometimes migraine, sometimes TMJ, sometimes we never figure out where it's coming from. It could be Meniere's disease causing them to have a sense of fullness, and yet their vertigo hasn't happened yet. So ear fullness is not always the eustachian tube. Ear fullness is kind of like this, facial pressure, postnasal drip, congestion. Like some of these symptoms can be really challenging for us to figure out. And we've got like all the testing in the world at our disposal, and we still sometimes don't know what to do. And sometimes we'll empirically just do a laryngotomy. If we're like, I don't know, I've got a couple patients like this, like your eardrum is totally normal, I have no idea what's going on, but we can try doing a laryngotomy. And then you do that and they're like, and you're like, oh my, okay, that doesn't make any sense. And then they know exactly when their tube falls out or crusts up or something. So it's clearly the problem, even though there's no exam finding or indication that it's the problem. But yeah, ear fullness, a lot a lot of different stuff it can be.
The other thing that would this could be a whole other episode that would drive me nuts, and you as well, I'm sure, is dizziness. Because it.
I hate that word. That's that's my congestion is dizzy.
Okay. Yes. Well,
but
I'm happy to. That's a whole. Yes. That's a whole can of worms. I can give you the short version.
Sure.
All right.
Yeah.
So, most of the information from the inner ear is going to be rotational. So you've got your 3 semicircular canals that are all orthogonal to each other, so all right angles to each other, and they're giving you rotational information, whether it's like turning your head or nodding your head or having your head go side to side. That's all rotational. So if the inner ear is malfunctioning, it will usually give you vertigo, which is room spinning. Vertigo is not a diagnosis. It's a sensation. It is the sensation of room spinning. It doesn't mean all vertigo is from the inner ear, but most inner ear dizziness is vertigo. And there's a big difference between positional vertigo, which is where you lie down and you turn to the side and you feel the room spinning, and postural dizziness, which is where you sit up and you get lightheaded.
Yes.
If you sit up and you get lightheaded, it's almost never from the inner ear. If you lie down and turn your head to the side and the room is spinning, it's almost always from the inner ear. And those two are confused very often. And so that little bit of information can help you parse out. And if you're having disequilibrium, which is this sense of imbalance, well, then they're going to see everybody and nobody's probably going to be able to figure it out. You could have them see ENT and ophtho and cardiology and neurology, because we're the 4 specialists that see dizziness. And by the time they see all of us and we've run all the tests, they're probably going to feel better despite us, not because of us.
Or still.
No, it's exactly.
They'll still feel dizzy.
That is a wonderful answer. Yeah, because it really was labyrinthitis and it just got better on its own.
The other one that drives me nuts is tinnitus, ringing in the ear, because you can't see that.
But it's a great thing. It's a great diagnosis to make snake oil for.
Well, recently, so I heard, and I want ask your opinion on this, because the newest thing coming out, and with all the longevity talks and live longer, avoid Alzheimer's, things you can do to improve your health, and so forth, is that having tinnitus, or however you say it, tinnitus, is a precursor to Alzheimer's. And that does that sound like crap, or no?
No. So tinnitus is often a mental health problem masquerading as an ear problem, because you should be able to ignore it. I have it, and you two will appreciate it, because I got it from Metallica concerts. Yes. So, I got it.
And I get it, but it's just a weird thing.
You got it the way God intended.
Now, and they got it from your Harley.
Yeah. Well, I always thought, no, but seriously, I have bad hearing in one ear. I had childhood ear infections that just ruptured, no tubes. It was the back of the 60s, and they didn't do that. And so I have bad hearing.
Did that. They just didn't do that when you lived at the 65th parallel.
Anyway, if we did the European way and just let it rupture. But so I have bad hearing, and I just go, that's the ear. It rings every now and then. The nerve's probably going more dead, and I blow it off, and it lasts 30 seconds, sometimes a minute, and then it's gone. No pain. So what do we do with people and patients like that who just have this intermittent 10 seconds, 30 seconds of ringing, nothing, goes away?
That's
just reassure
physiologic. Them? No, that's physiologic. That's not pathologic. So when you have these fleeting episodes of tinnitus and hearing loss that last like a few seconds, and it just goes like, and then you're back to normal, that's not anything that needs to be worried about or worked up or anything like that. But it's the persistent tinnitus that's a problem. But there's a phenomenon called sudden sensorineural hearing loss, where you'll just like that boop will happen, but it never stops, and your hearing is out. And you can end up with a little hearing loss or a lot of hearing loss. And the sooner we see those patients, the better, because we might need to put them on a high dose steroid. We might inject steroid into their middle ear, might send them for hyperbarics. So there's, but the sooner the better. So if there's like a persistent, but if it's only a few seconds, then I wouldn't even think that that's something that needs to be.
So treat that like a retinal detachment presentation when someone all of a sudden has a big field of vision loss. That's right. Like this is an ENT emergency, persistent ringing, sudden change.
I'm just assuming you're correct with the retinal detachment thing, because I have no idea what to do with eyeballs. But yes, it is. They need to come in. They need a hearing test. So we need to manage that with steroids. But what we were saying with the tinnitus, if they have like persistent, bilateral tinnitus, oftentimes either they should be able to ignore it, and if they can't, it might be because there's an undiagnosed or undertreated anxiety or depression that's not allowing them to ignore it. Because, especially anxiety, they've got this increased vigilance. Their brain is looking for threats, and it's going to gravitate towards this thing that they're trying to ignore. So they're not able to get their attention away from it unless you treat their mental health. And then that can help them to be able to live a better life. Or if they have hearing loss, hearing aids. They need hearing aids. Do you have hearing loss in one ear? Are you wearing a hearing aid in that ear?
I don't wear a hearing aid. I'm stubborn,
No?
and I don't. It now.
Okay.
So I know I will need to, and the kids get mad because I hear things differently than they're
Differently,
saying, and
yeah.
it makes for a funny conversation. But
Well,
I won't. I don't want to do it.
okay. Well, your question about tinnitus and Alzheimer's is not tinnitus and Alzheimer's. It's hearing loss and Alzheimer's, or
Yeah.
not Alzheimer's, but dementia. And what happens is if you like you said, longevity. So one of the biggest predictor of health and longevity is the strength of your social connections. Well, you need to have meaningful interactions in order to maintain those social connections. So if you're not hearing people, then you're not going to be able to participate as much. And then you're slowly or quickly going to stop participating. Those social connections are going to break down. You're going to develop social isolation, which can develop into depression. And then that feeds into the dementia.
Yeah.
So that's where the hearing, it's important to be able to hear and understand people in order to maintain those social connections, which is why it's important to hear.
That makes
You
sense
might
to
wanna
me, and
get
that's
my
what
hearing
I
aid.
thought. And that's what I thought, because
then,
I thought that's the
yes.
tinnitus is not a predictor of Alzheimer's. It's just a correlation of hearing loss than
Yeah.
the downstream effects. Yeah.
Yeah. It's like
So
the same reason that we see more shark attacks when ice cream sales go up. It's not, sharks are not attracted to ice cream. It's
No, they're
correlation, not
attracted to
causation.
people at the beach, and they usually go to the beach during the summer. Like,
Exactly. Yeah.
And so what's the deal with hearing aids? Are they getting any better? Like, they seem to cost so much money. You can get a TV, like a what size TV now, like an 80-inch for like $300, but the hearing aids, it's like a rip. I don't know. Still a rip
Well,
off.
the TV thing to me is just insane. Like the
right?
fact that you can get an 86-inch TV for like less than $1,000, which
know.
is just preposterous. Like, how is that even possible that that society has made that happen? Right.
Is it demand versus
Well, it's obvious. It's
I know,
all
but the
supply and demand.
Yeah,
But
but-
they've
But how is the cost? How are they able to bring down
the cost.
production costs so low that can actually happen?
Yeah,
We need to do a show on this.
I know.
No, that one is.
But my dad, who is, bless his heart, 87, and he's like, my hearing aids aren't working. I need a new pair, but I don't want to spend the money yet, or I want to wait for my taxes. But
Why don't wait till I sell my house for $350,000 to buy it's just.
Why are they? Is there any advances coming along in that? Because you hear these kids, and people that aren't able to hear, and these kids with sensory neural damage, correct, that can actually hear for the first time, and it's life changing. But for like elderly hearing loss, like all those aging hearing loss.
Well, I mean, they have the over-the-counter ones, and the over-the-counter ones, like they're more for people with like really mild hearing loss that probably aren't getting hearing aids anyway. So the cheaper over-the-counter ones that you can be at like Best Buy and maybe program yourself they're just underpowered for people that really, have more severe hearing loss. So like grandpa who has trouble understanding even with his hearing aids, he needs real proper hearing aids. He needs to work with an audiologist. He needs to have a good relationship with that audiologist so they can help him as best, because he's going to need to come back for multiple visits. He's going to have some issues. So, it's not just, it would be nice if there was a technology that you just like plug and play and it's easy to use, and they can be, but it's complicated is unfortunately the answer to most things.
It's not like cataract surgery where you can just give somebody a cochlea.
Put in that new lens and then they're great.
Right.
Yeah.
Well, that's
just
cataract surgery, that has got crazy. You can get tinted cataract implants. You can get one near and one far. Like, it's
sign me up.
Yes.
And then that patient's going to come to me with vertigo, right? And be like, "Well, I'm feeling dizzy."
I love it.
I had one patient, and we'd known him he'd done some work around our property for us, and he did ortho, like I don't know that it was LASIK. I can't remember. And he had one near and one far. So it was great. He threw his reading glasses away. And I'm like, that just sounds like way too risky for me. I don't want that.
No kidding. Any other pearls, tips, or thoughts you want to get in before we wrap up the show?
I think I'm tapped. I'm tapped.
Perfect.
Remarkably.
No, that was super duper helpful.
Oh,
Like,
so I got to ask, with a little prompting from our friend Desiree here, give us a great 80s movies quote that you want to share just for fun. Can you think of one?
Yeah. So the one that I probably quote, The Princess Bride. I mean, Star Wars, Princess Bride. I will die on the hill that The Princess Bride was the greatest movie of all time because of the mass appeal. Like, there's something for everybody. It's not too graphic for the kids. Everyone gets the jokes. Like, it's so there's a scene when they're in the fire swamp and she goes and Wesley says, well, I wouldn't build a summer home here, but the trees are actually quite lovely. So whenever we're in a new place, my wife knows that I'm going to be saying that. She's like, oh, you know what? The views are really nice here. I was like, well, I wouldn't build a summer home here, but the trees are actually quite lovely.
I love it.
Like when the mutton's really fresh.
Oh, when the mutton's nice and lean. An MLT, yes, when the mutton's nice and lean. Yeah.
It really was like transcendently brilliant. Like there's every once in a while that happens. And there had been talk apparently of a sequel, but I think they're scared to death that they're going to destroy whatever they had.
Yeah.
Huh.
Yeah. And there's just something magical about that cast,
no kidding.
like that original cast.
Wow.
Unreal.
Yeah, just like Beetlejuice they were gonna make a sequel of Beetlejuice, and it was really crazy. Yeah, I was getting tattooed for like 18, I think it was 15 hours, and so a tattooist would just put movies, and then he knew everything about all these movies because he watched movies
watch movies all the time.
Shouldn't
you be paying more attention to my tattoo and less to the movie that's on the screen?
Well,
like,
you just
why are
you hear it, you're like, and he knew he had tattooed some of these guys. Like it was fascinating to talk to him. He's like, and he was like, it was going to be like Beetlejuice in Hawaii or some completely insane thing. And I'm like,
please
put the acid away, guys. Just leave it alone.
Like the first Ghostbusters, there shouldn't have even the sequel was to the original wasn't that good. But that there's just sometimes that magic between the cast, and it's just unbelievable.
You're right. Brad, I don't know if you're taking new patients or want to give out your info where local patients could find you.
No.
If so, share. Okay, moving right along. People want to check out your podcast.
Yes.
Then is it all on all platforms, Apple, Spotify, and that's the Physician's Guide to Doctoring with Dr. Bradley Block. Are you on any social media channels where people can follow you?
I am I'm LinkedIn. If you want to find me, Bradley B. Block, MD, and on the artist formerly known as Twitter for however long that lasts until it implodes, and on Instagram, on both of those at Physician's Guide.
Awesome. Thanks for being here and sharing your wisdom. It was really good. And I know people are going to actually like this episode.
Yeah, a lot. It's really helpful, practical information.
Exactly.
Sure.
So thanks again. All right. See ya. All right. That's a wrap with Dr. Bradley Block. Huge thanks to Dr. Block for hanging out with us and spilling some serious ENT wisdom. And we hope you got as much out of this as we did. Surprise about the earwax. Dr. Block isn't just a top-notch ENT doc. He's also a pro at making complex stuff sound simple.
Yeah, don't forget to dive into the Physician's Guide to Doctoring podcast. It's packed with more goodness and more goodies from Dr. Block. It's packed tighter than your ear canals with wax. So that's it for today's episode from BS Free MD. Big thanks for tuning in. We'll be back soon with way more straight up, no nonsense medical insights.
And I can't wait for this week's shout out because Tim is gonna love it. We love our fans, especially when you reach out to tell us about how much you love us.
Yes. Big shout out to Dr. John McDonald. I had a little email back and forth with him. It was awesome. He was reading mammograms and laughing. Not at the mammograms, but at BS Free MD, which is good. That's a good thing to be doing that. So anyways, Keep listening, John. We really appreciate it, and love that there's actually physician listeners that think our stuff is pertinent.
And
so
Tim
that's
loves
cool.
it when he can make people laugh. That's his goal in life. So, all right, everybody. Thanks again. Check us out online. Sign up for Truth Serum, and we'll see you all next time. Now, a final word from our sponsor. At Pearson Rabbits, they understand that life can change in an instant. It's hard to imagine that a sudden illness, injury, or catastrophic event could put you and your family in a devastating financial situation. Physician-founded and physician-focused, Pearson Rabbits builds human connections before they create quotes. Visit www.pearsonrabbits.com today and embark on a journey of safeguarding your future. It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
But we try to keep BS Free MD as raw and real as possible. We can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.